would like to invite our third speaker, Dr. Riyad Saeed. It's my pleasure to present our nephrologist, Dr. Riyad Saeed, and it's my pleasure to present a nephrologist as we are in good relation with our highly appreciated colleague of nephrologists. Dr. Riyad Saeed is graduate from Cairo University Medical School in 1968. He's trained in both internal medicine and nephrology at Northwestern University, 1972 to 1977 in Chicago, USA. He has an American Board of Internal Medicine and American Board of Nephrology, and he's a fellow of American Society of Nephrology. He's a professor of medicine and nephrology in Jordanian University Medical School, 1997. Dr. Riyad Saeed is the past chairman of ISN Comgan Medical East Region, and he is an ISN Council member for the Middle East from 2005 to 2011, and he's a recipient of ISN Pioneer Award in the Middle East region in 2017. Dr. Riyad Saeed is the past president of Jordan Society of Nephrology from 2002 to 2006, and he is the past president of the Arab Society of Nephrology and Renal Transplantation from 2000 to 2002. He has more than 50 publications in the field of nephrology in local, regional, and international journals, and he is now the director of medical education and training program in Jordan Hospital in Amman. It's our pleasure to hear to you, Dr. Riyad. Thank you. Stage for you.
Bismillah ar-Rahman ar-Rahim. Thank you very much. I'd like to thank Dr. Basil for inviting me here to be with you today, and thanks the Jordan Society of Rheumatology really for hosting this talk. My task, sorry, I was really sick for the last couple of days. The task that was given to me was told initially that's 30 minutes, and last night I was surprised that's 25 minutes. I tried to do my best to cover the talk within this frame time. Well, as we heard earlier, systemic lupus erythematosus is a chronic, complex, and often disabling disease. It's highly heterogeneous, affecting a range of organ tissues, as you'll see, central nervous system, lungs, blood, heart, as we hear the multi things, and the kidneys, by far to me, is the most important organ to be affected. And we know that lupus nephritis is a serious progression of lupus nephritis, and as many as 50% of patients with lupus, they will develop lupus nephritis. And lupus nephritis is a clinical diagnosis. Is a clinical diagnosis based on proteinuria and sometimes hematuria. We don't really wait for a kidney biopsy to diagnose lupus nephritis. And we know that the outcome is a straightforward outcome. If you early response, treatment correlates very nicely with the outcome. And it's debilitating, costly when it really ends with end-stage kidney disease, dialysis, and usually death. Severe lupus nephritis affects almost end-stage renal disease within 15 years of diagnosis, up to 30% of patients. This is the slide showed for the what we call standard mortality ratio. As you'll see in what being calculated, basically the ratio between the observed number of deaths over the expected number of deaths. See what will happen with patients with lupus as a whole, and when you see patient without renal disease, it's around 5%. But when you have renal disease with damage, it comes up to 15%. Look about when you have it with end-stage kidney disease, usually it goes up to 65%. This is the mortality. And we know that patients with renal replacement therapy, age 30 to 40 years of age, they have at least 18 times higher mortality than general population. So really, if patient with lupus developed end-stage kidney disease, that's a dismal point. Now, we went ahead, over the years with the improving of the outcome of renal diseases. As you'll see here, in the decades of 80 to 90s, that the mortality used to be quite high, the survival is low, but now we really have good chances for survival for our patient with lupus nephritis. Well, why this has happened? Because early diagnosis. The earlier you diagnose your patient, the better will be the outcome. More importantly, aggressive immunosuppressive therapy that we are really using, and we have also more improved supportive care. Now, thanks to combination of methylprednisolone initially, and then the cytotoxic agent with methylprednisolone pulse therapy, usually that added a lot into the improvement. Do we need a kidney biopsy for a patient with lupus nephritis? Well, we'd like to still, that lupus is a clinical diagnosis, proteinuria, hematuria, Do we need the kidney biopsy to establish lupus nephritis? The answer definitely is not. But we need a kidney biopsy in lupus patient to assess disease severity, the classification of the disease activity and chronicity, and to help guidance concerning therapy, because that staging is really quite important for us. Now, we have, this is the ISN PR classification, stage 1 through 6, and we'll go through some of them now. But a couple of points really, when we talk about diffuse nephritis or focal nephritis, that refers to the number of the affected glomeruli on the biopsy. Focal means some normal and some abnormal. Diffuse, we have most of the glomeruli are affected. Look about here, more than 50 or 60%. Then we talk about global or segmental. Segmental, it's really one part of the segment of the glomerulus is affected, while global is all. So we have diffuse proliferative, diffuse global, diffuse focal, and focal proliferative GN. Why really lupus is unique? Lupus is unique, really affecting all this. It can have the spectrum of affecting all these kind of troubles. If this is the capillary loop that may be to be inflamed, this is the mesangium, that's the capillary loop itself, that's the basal membrane with the cytoplasm fenestration, and that's the podocytes with sending its food processes. If the disease affects the mesangium, usually it's going to see stage 1 and stage 2. If the disease affects the podocytes, you're going to see basically stage 5, which is nephrotic presentation. If the disease affects the endothelium, which is by far the vast majority, you're going to see stage 3 and 4, which is inflammatory, severe inflammation, and sometimes necrosis. So lupus is really unique. You can have the combination of all. You have mesangial proliferative, you have type, you have class 3, 4, you have 4 and 5, and all different combinations. Now, this is just mild, to see mesangial, stage 1. You have some immune fluorescence, electron microscopy. Luckily enough, you find something there. Stage 2, mainly look about this proliferative mesangial cells increased, more immune complexes on the immune fluorescence, and more immune deposits on the electron microscopy in the mesangium. If you have focal, as you'll see, around less than 50% of the glomeruli will be affected. Segments of the glomeruli will be there, and the immune fluorescence will be that's mostly across the whole. We call it full house involvement. And these are the immune electron dense deposits that you're going to see. Stage 4, more advanced, you're going to see with necrosis. And if you're lucky enough, you'll see the electron microscopy. That's what we call classical subendothelial deposits. And if you are fortunate, you see these inclusion bodies in the glomeruli. Stage 5, you don't see any inflammation or anything there, but you're thickening of the basement membrane. With the thickening of basement membrane on the immune fluorescence, you see this classic granular deposits of IgG, and then here you're going to see in the electron microscopy subepithelial deposits. So that's stage 5. And advanced one, basically, that's what you have, burned out nephritis. So really, this is reflected into clinical practice? Yes, you can really see if a patient will present with only hematuria and asymptomatic proteinuria and hematuria, most of the time he's going to fall into class 1, class 2. If he's nephrotic syndrome, that means he's going to have class 5 by far. But there is an overlap. If he presents with acute GN, well, you are going to see really mostly stage 3 and 4. Chronic renal disease usually will be stage 6 most of the time. Now, how we treat patients with lupus nephritis? There is a category now we talk about treat to target in ACL nephritis. What that means, really, our goal of therapy is to induce remission and prevent flare. In the meantime, decrease damage and prevent end-stage renal disease. So it's a balance, really. So induce remission and prevent flares, prevent damage and end-stage kidney disease. How we can achieve all this? Early recognition of the disease. We heard about early diagnosis. Maintenance treatment really for not less than 3 years. Use of anti-malarials, lowest corticosteroid therapy, and control comorbidities in lupus nephritis patients. Now, but how we can define the response for our therapy? What are the lab's criteria that we look for really? Well, there is no definition so far well accepted about the definition of complete remission. As you'll see, the ACR, the lunar, the ALMS axis, all they have variable degrees of renal manifestation to call it improvement. Proteinuria by far is the most important thing, and serum creatinine is the second. But we have here really KDUP guidelines. They define for us the complete response, return of serum creatinine to previous base value, plus decline in protein excretion to less than 500 milligram. Partial response, stabilization or improvement of serum creatinine, but not normal, plus 50% decrease in the protein. If we have nephrotic range proteinuria, 5 grams. If we have less than 2.5 grams, that we call it partial remission. Deterioration, there is no improvement at all, or an increase in the serum creatinine and increase in the amount of protein. This has not been validated. Now, how we monitor this response? We look in the kidney itself and outside the kidney. In the kidney, the urine sediment is the thing that we look for. How bad the hematuria, how bad the proteinuria. And then we look about the plasma serum creatinine we have. In the kidney, extrarenal symptoms, serology, complements, and NAs and DNAs. What are the clinical predictors for good outcome or poor outcome? If a patient presents with hypertension, with anemia, high baseline serum creatinine, heavier proteinuria, delay in therapy, all these are clinical disorder, predicts poor prognosis. Histologically, the biopsy here will come to play. If we have class 4, that's much worse than class 2. If there is necrosis, and we know the activity and chronicity indices that we can count. If there is crescent or no crescents, usually that's poor prognostic. Fine. Racial, epidemiological, African Americans, male gender, low socioeconomic status, younger age, they have poor prognosis. What are our guidelines, the evidence base for treatment of lupus nephritis? We have here, just to outline to you what we really mean when we say level 1, that means that recommend. When we say A1A, that means you have supported by evidence of high quality randomized controlled trials. Most patients should receive this treatment. When we say recommend, means they should receive the treatment. Level 2, we suggest, that suggestion, that different choices are available to you and classified from A, B, C, and D. So the best recommendation really will be if you have category 1. In spite of we have more than 30 recommendations on suggestion of lupus nephritis, only 6, look about 20%, they are category 1A and 1B. So really we have very poor clinical trials. Now, generally what we have, now all patients, regardless of their degree of renal involvement, antimalarial should be part of the therapy. I stress this. Antimalarial should be part of the therapy, even during pregnancy. That's really should be, unless there is a very strong contraindication. Why really? Observational studies showed onset of lupus nephritis will be delayed, flares of lupus nephritis will be delayed, and end-stage kidney disease can be delayed. So most of our patients, they should receive antimalarial. Class 2, class 1, minimal mesangial. What the suggestion is, patients with this class should be treated by extrarenal indications. As a nephrologist, we don't really deal with that, and our colleagues, the rheumatologists, they will handle that in the way that they deal with other extrarenal manifestations. Class 2, and that divided into 2 things. If they have less than 1 gram protein, they will be treated like extrarenal clinical disorders, and that's not graded. But if they have proteinuria more than 3 grams per 24 hours, steroid therapy, calcineurin inhibitors, and we treat them as minimal change disease. I jump to type 5 because I'd like to keep the rest of the talk for class 4 and 3. Class 4, which is the nephrotic, most of the time, suggests that patients with class 5 lupus nephritis, normal kidney function, non-nephrotic range proteinuria, be treated with antiprotonic, antihypertensive medication, ARBs, and only receive corticosteroid or immune suppressive therapy as dictated by the extra-renal manifestation of lupus. They have something for indication for that, we give them. Now, but if they have nephrotic range proteinuria, corticosteroid is the cornerstone of the management plus additional agents. Cyclophosphamide, CNIs, MMF, or AZA, as you'll see, all of them graded more or less suggestion, 2C, 2C, 2D, 2D. Advanced stage, which is class 6, basically treated conservatively, supportive measures, and if there is an extra-renal manifestation, they should be treated accordingly. Now, the major thing really, how we're going to treat class 3, 4 lupus nephritis, which most of the time we call it diffuse proliferative glomerulonephritis. There are two parts of the treatment, induction therapy and the other maintenance therapy. Now, what's the aim really of the induction therapy? Our aim is usually this being the acute phase of the disease, whether during presentation or basically after flare. Acute phase of the disease at presentation or during flare follow-up. Goal is to induce remission, because it has been shown that once you induce remission, your survival really correlates with that. There is a strong evidence that steroids plus cytotoxic agents give superior outcome than steroids alone. If you look about this, pulse plus study lupus nephritis, as you'll see, methylprednisolone, cyclophosphamide alone, and combination, doubling of serum creatinine was less, need for treatment, other treatment is less, not dying basically is less. So really, combination therapy is the master management. Now, what will be the initial treatment? Most of us as physicians, in the old days and still, we accept that cyclophosphamide is more potent and allows more rapid control of severe disease. But do we really need all our patients, they need cyclophosphamide, or we have other options? Well, let's see. Is cyclophosphamide better than AZA? Is IV cyclophosphamide better than oral? How much cyclo would like to use? And is myclophenolate good enough for us? These are the alternatives that we have. Let's talk about cyclophosphamide. Is it better than AZA? Well, there is only one controlled study head-to-head, randomized controlled study, and showed no difference in outcome. So they are equally effective, but the European, they exclude severe diseases, and as a patient required an additional dose of methylprednisolone. What about IV versus oral? Well, the only advantage of the IV, high intermittent dosing, improved therapeutic index, may reduce neutropenia and site infection, and again, compliance. Patient, we ensure that he received the medication. There are no controlled studies. Now, how much cyclophosphamide is required? Now, well, the Eurolupus trial, when they studied 90 patients, and they compare high-dose cyclophosphamide, total around 8.5 grams versus 3 grams, that's 500 milligram every 2 weeks for total 6, and here 1 monthly, in addition to methylprednisolone that received. This group, they followed after that with azathioprine for the 41 months. What's the outcome? Look, see. Efficacy, free of failure, the same. Flare, the same. But infection is higher with the high dose of cyclophosphamide. So the conclusion of this study was no difference between high dose and low dose cyclophosphamide concerning remission, flare, but infection was higher up. Is myclophenolate good enough as a replacement? Well, let's see what will happen. All of you are aware of the ALM study, which is an international study, around 370 patients randomized into 2 groups, 185 in each. One received, all of them, they are on prednisone. The other one received myclophenolate, and the other received IV cyclophosphamide 1.5 gram to 1 gram monthly for 6 months, and then continued the observation. The two groups were really identical. Gender, classification of the stage of the renal disease, creatinine, proteinuria, complements, and C4, all were really identical. What happened? There is no difference concerning 12-month outcome, proteinuria and GFR. Around response, 56%, 53% in the two groups. So no evidence that myclophenolate is superior to cyclophosphamide with this randomized control study. But again, MMF did not prove superior, but not inferior. Look about, not inferior to IV cyclophosphamide. Response at 6 months, it was really more or less equal. What about really in severe renal disease when we have crescents? Which drug really to go? Well, there is one study, nice study here, around 52 patients with more than 50% crescent. They randomized into myclophenolate and cyclophosphamide. The outcome was better in the MMF group, 54% complete remission, 11 relapses, and compared with the cyclo, it's usually lower. What about patients when they have GFR less than 30? There are 20 patients myclophenolate, 12 patients cyclophosphamide. No significant difference really in the outcome. So the recommendation came in based on this information. For lupus nephritis 3 and 4, we recommend, that's the first time you hear recommend, therapy with corticosteroid. That's the only one, 1A. That means every patient should receive steroid, combined with either cyclophosphamide or MMF. 1B recommendation. That's a very strong recommendation for this group of patients. Now, you have the choice whether to go with Eurolupus trial or to go with MMF protocol. Now, what about calcineurin inhibitors? Well, we know now, we heard about multi-target add-on tacrolimus or cyclophosphamide. There is a nice study here. Tacrolimus was added to myclophenolate in this group multi-target study versus IV cyclophosphamide. And the outcome really was better if we add a fourth drug, steroids, myclophenolate, and tacrolimus. And again, there's another study showed the free of relapse, and really it's better with the multi-target organ study. What about, you heard now the ORATS phase 3 volcosporin, and that's coming to the market more and more. That's controlled study here showed the use of 23.7 milligram and 39 milligram versus placebo, and they followed them really for this period of time, 48 weeks. And with really forced tapering of the steroid, very low dose of steroid. What they found, usually complete remission was observed in the patient who received voclosporin, and that's really something in the future is going to happen. Now, this is the initial therapy. What happens if your patient, while you are giving all this, and he gets worse? What are you going to do? He's not responding. Rising creatinine, proteinuria during the first 3 months of your induction. Change therapy. If he was on cyclophosphamide, switch him to MMF. He was in MMF, switch him to cyclophosphamide. That may help. And a biopsy should be considered at this point in time. Now, what about the maintenance? Your patient got his treatment, his initial phase of therapy. Now, what's the goals of our therapy really? Maintenance, to prevent renal flare, protect from silent progression of the disease, minimize the side effect of toxicity. Cyclophosphamide, AZA, and myclophenolate. Now, in order to do this, what we have to prove the equivalence of, because of toxicity of cyclophosphamide, equivalence to AZA and myclophenolate, and because of the cost difference between Imuran and the safety in pregnancy, we have to prove equivalence between AZA and myclophenolate. Well, the studies are available. Maintain study showed no difference in the maintenance between MMF and AZA. But in the ELM study, later on there was something in favor of the treatment with MMF as a maintenance therapy. So the recommendation came in as, recommend after initial therapy is complete, Patient should receive maintenance therapy ASA or MMF with this specified dose, and that was 1B. That's a strong recommendation. We suggest that calcineurin inhibitor or low-dose corticoid used for maintenance therapy if the patient cannot tolerate MMF or azathioprine. We have to give him something, and cyclosporin usually will be the drug of choice. Now, for how long really we have to keep maintenance therapy? At least for 1 year before we start cutting down. Maintenance, no way, we don't know really for how long. We have patients on 3 years currently, and we are daring to stop the medication. But gradual tapering of the medication will be really allowed within 1 year after that. That's category D. Now, if complete remission is not really achieved after 12 months, what are we going to do? Here, consider kidney biopsy. It's not graded. While maintaining therapy is being tapered, if kidney function deteriorate or proteinuria worsens, we go back to the previous dose that the patient was in remission. What about relapse? If a patient relapse, lupus nephritis after complete or partial remission be treated with the initial course of therapy that he received and he responded well. If resuming the initial therapy puts some trouble or the patient is not happy to take cyclophosphamide, then you can go with non-cyclophosphamide based regimen, and that's category 2B. So the summary of the standard of care for lupus nephritis is steroid, 0.5 gram pulse steroid daily for 3 days, plus oral steroid later on, myclophenolate or cyclophosphamide, follow up by maintenance MMF or ASA if not tolerated or during pregnancy. Chloroquine should be part of the treatment, ASARBs. So this is the standard. If the patient fails all the standard therapy, what are we going to do for him? Leave him alone? Then will come the B-cell targeted therapies. B-cell targeted therapies, we know that the B-cell produces cytokines, present antigen, interact with T cells, mature into plasma, a lot of antibodies will be performed, and that will attack immune complexes in the glomerule. What are the B cells really targeted? We talk about rituximab, we talk about alameted, and pirimab. Now,
Dr. Riyad,
one
please.
study about
Dr. Riyad.
this, yes, this is the basically this summary, and that's it. The lunar study you should be familiar with when they really have double-blinded randomized controlled study, 52 weeks trial, efficacy in lupus nephritis 3 and 4. Rituximab add on to steroid therapy. What happened really, they gave them the steroid for this period of time, and rituximab placebo day 115, 158, 150, 182 for 52 weeks. No difference really for this, no difference. So that's relevant and no benefit at 12 months. What about refractory? There are a couple of articles really, Cambridge experience, the French quality and the British, they have some evidence that it may work. And is this, this is no steroid therapy, and basically this group studied 50 patient observational study when they give rituximab 2 doses is methylprednisolone, and this has been tested up to this period of time. 72% they have complete remission within 37 weeks, and 90% of the patient received complete remission. I think I'll stop here. Rituximab start getting its foot really in the management of our lupus patient on refractory cases, but not really as a primary goal of therapy. The mainstay of therapy really still holds true. There are some more biological agents available. I don't have really the time to go through that. Thank you for listening. Thank you for inviting me.
Thank you, Dr. Riyad, for this nice informative presentation. Unfortunately, we don't have time for a question. Unfortunately.
I'll give one question.
Okay, it's one short question? Okay.
Just a couple of brief questions, please. You mentioned that renal biopsy isn't required for diagnosis, but we know that in lupus, particularly those with antiphospholipid syndrome, may have thrombotic microangiopathy, and the treatment is different from lupus nephritis. How would you distinguish between those on clinical grounds? And the second question, how do you manage lupus nephritis during pregnancy? How do you induction of lupus nephritis in pregnancy?
Induction, well,
Yes.
okay. Well, concerning the biopsy, for straightforward kidney biopsy in lupus patient, we do it all the time. But based on clinical criteria, patient has clinical criteria for lupus. He has a proteinuria, hematuria. I will not biopsy a patient without hematuria, without proteinuria, because this is not really lupus nephritis. Okay? If I don't have clinical indicators, how I'm going to treat him? There is no criteria for me to treat the patient. فبالتالي the kidney biopsy here is going to be a waste of time. If it is part of protocol study, yes. If it is not really, you're going to treat a patient if there is no protein and hematoma. What normal kidney function, creatinine, proteinuria, nothing there. Why the kidney biopsy? Okay, now for pregnancy, if the patient comes pregnant, then we know that basically pulse steroid therapy is the management, and azathioprine will be the treatment of choice, because MMF is contraindicated and cyclophosphamide is contraindicated. Unless really if you feel early in the pregnancy, sometimes termination of pregnancy will be the choice for such patients. You can use it. Target, yes, you can, because from the experience of transplantation, tacrolimus, cyclosporin, and others, really we have no trouble with them during pregnancy.
شكرا.